Hello everyone, welcome to this class where you guys will learn about vertebrobasilar artery syndrome. This is an attempt to kind of help you all understand this topic. So let's get started. So before we dive into different kinds of vertebrobasilar artery syndromes, we need to remember some key rules to kind of ace this topic, okay? Number one is to remember your brainstem lesion location. If there is a face which is involved, it's always going to show you ipsilateral defects. If your body is going to be involved, it is going to show you contralateral deficits, whether it's your sensory involvement or if it's your motor involvement. Now, you also have three structures, right, where you have these syndromes going on. And if it's the midbrain which is involved, you always have to remember two cranial nerves, your cranial nerve 3 and your 4. Pons is going to have 5 to 7 or 8 cranial nerves. Okay, so whenever the question hints you a fifth cranial nerve or an eighth cranial nerve or a seventh cranial nerve, it's almost going to hint you towards your pontine syndromes. And your medulla is going to have 9, 10, 11, 12, so 4 cranial nerves. The third principle to remember is the location of these brainstem syndromes. Okay, because we have on the medial side, we also have the lateral side, right? If you look at your pontine syndromes or medullary syndromes, we have medial and lateral. So if there's a lesion on the medial side, M stands for medial, right? So we also have to remember 4 structures which are going to be involved on the medial side. Number one is your motor pathway, which is responsible to carry your tone, and obviously it is going to lead to contralateral body weakness. Medial lemniscus is going to cause you a contralateral fine touch vibration proprioception loss if there is an involvement of your medial lemniscus. Medial longitudinal fasciculus is going to be your eye movement, which is going to be affected, and motor nuclei of the cranial nerves are going to show you ipsilateral dysfunction of your cranial nerves, right? So 4 M's on the medial side. On the lateral side, it's going to be 4S. Okay, 4S structures. The first S is your spinocerebellar tract. And if there is a lesion of the tract, it causes ipsilateral cerebral ataxia, since you know your cerebellar lesions are always going to be ipsilateral. And if there is a cerebellar involvement, it leads to ataxia. Moving on to the second S is your spinothalamic tract, especially your lateral spinothalamic tract, causes a contralateral pain and temperature loss. Third S is your sympathetic fibers, where you have ipsilateral Horner syndrome, your ptosis, meiosis, and anhidrosis forms your Horner syndrome, and you will have ipsilateral presentation of this if there is sympathetic fibers being involved. And the final S is your fifth cranial nerve nucleus, which is your trigeminal nerve, responsible for your sensations of the face. And if the trigeminal nerve is involved, it is going to cause you ipsilateral facial pain or temperature loss. Now, let's try to break down each of these syndromes, like your medullary syndrome, your pontine syndrome, and then your locked-in syndrome, right? So starting off with the medullary syndrome, again, like we said, we have medial lesion. We can also have a lateral lesion. So remember, if there is lesion on the medial side, what should you remember? The 4 M's. So let's apply those 4 M's into these, into this medial medullary syndrome. So number one, since it's medulla, you know your structures which are going to be involved, right? So it's going to be 9, 10, 11, 12 cranial nerves. So on the medial side, it's going to be your cranial nerve number 12. Then on the medial side, you also have your motor pathway. That's your second M, which is going to show you contralateral weakness. And then your third M is going to be your medial lemniscus, which is again going to cause a fine touch vibration and proprioception loss, which is again going to be your deeper sensations. Okay, so you see, you need to remember just the medial lemniscus and your cranial nerve 2, which is going to cause ipsilateral tongue deviation, and contralateral hemiparesis, because you have your motor pathway, which is also going to be involved. So we have those M's definitely seen in medial medullary syndrome. Okay. Now let's try to look into lateral medullary syndrome, which is also called as Wallenberg syndrome, which has been, very important for NPTE. So what is Wallenberg syndrome or lateral medullary syndrome? Should you be concerned about the medial structures like the 4 M's? Not really. So now your eyes have to look at the lateral structures. Are they giving me anything about cerebellar lesion? Are they giving me anything about sympathetic involvement? So let's look at that. So number one to remember is again your cranial nerves. Your cranial nerve 9 and 10 are going to be involved. And it causes dysphagia, hoarseness of voice, and your gag reflex is going to be diminished. So definitely you will see those symptoms or those keywords given in the question stem. And you will also see your first S, which is your spinothalamic tract, which is going to cause contralateral pain and temperature loss. Spinocerebellar, which is going to be ipsilateral. Sympathetic fibers, which is going to have ipsilateral Horner syndrome, and your trigeminal nucleus, which is your sensory cranial nerve nucleus, which is going to cause ipsilateral pain and temperature. Now, did you find those four S in the lateral medullary syndrome? Yes. So whenever the question hints you towards cranial nerve 9 and 10 with these four S, you need to think about your lateral medullary syndrome. And that kind of wraps up your medullary syndromes. The medial is always your M's and lateral is always your S. Okay. Now, moving on to your Pontine syndromes. Now, the most important Pontine syndromes will be covered in today's lecture. Number one is your medial inferior Pontine syndrome. Now, if you go back to the slide, if you look at pons, I told you it's going to be either your fifth, sixth, seventh, or eighth cranial nerve, correct? So let's try to see if your Pontine syndromes are going to involve those cranial nerves. And because we're starting with the medial side, you have to think of your four M's. Either of the four M's are going to be always given. So if you look at the cranial nerve involvement, there you go. It's your sixth cranial nerve, which is going to be involved. So we have one down so far. And the first M is going to be your motor pathway, which is going to be contralateral hemiplegia, right? Now, your cranial nerve 7 is also going to be involved, and that's going to cause contralateral lower facial weakness because this is an upper motor neuron lesion, right? Pontine area, and it causes contralateral lower facial weakness, okay? So when these are given in your question stem, okay, or they're given as your keywords, especially hinting towards your cranial nerve 6 and 7, it is going to be your medial inferior pontine syndrome. And remember, it's medial. It shouldn't be having ataxia symptoms. It shouldn't be having your Horner syndrome. It shouldn't include any of those four S's, right? Like your spinothalamic and so forth. So remember, you always have to think about what are those M's? Are those M's given in the question keyword? Okay. Now moving on to the lateral inferior pontine syndrome. Now, because it's lateral, you have to think about those four S. And remember, we've covered 6 and 7 cranial nerve. You also have seventh one repeated over here. Now, seventh cranial nerve, over here, it's the cranial nerve nucleus or the cranial nerve itself, which is going to be involved. And that is the reason why you would see an ipsilateral facial paralysis. So remember, the medial is going to have a contralateral weakness on the lower face, but your lateral is going to have ipsilateral facial weakness. Now, moving on to your cranial nerve 8, right? You know it's going to cause vertigo, nystagmus, deafness, and tinnitus because it is your cranial nerve 8, right? Now, what are the four S's again? Back to the same story. Cerebellar tract, which is going to cause ataxia. Trigeminal nucleus, which is going to cause facial loss on the ipsilateral side. Spinothalamic tract, which is going to be your contralateral pain and temperature loss. And sympathetic tract, which is going to cause you Horner syndrome. So you have your four S's mentioned on the lateral side again, along with your cranial nerves 7 and 8, which is going to hint you towards your lateral inferior pontine syndrome. So pretty easy, right? Remember M, mediastinal, L is or the lateral side is going to be your 4S. So if you remember the structures being involved, it kind of hints you towards is it a medial stroke or is it a lateral stroke, right? So now moving on to we finished medulla, we finished pons, and we have one more area to be, we took actually, like remember for NPTE, it is going to be midbrain syndrome. Okay, now midbrain syndrome, again, Weber's syndrome is super duper important. And let's dive into what exactly is Weber's syndrome. Now, remember, if you don't remember anything of Weber's syndrome, remember this mnemonic, midbrain has the medial web. Why do I say that? So midbrain lesion hints you towards your Weber's syndrome. So midbrain has the medial web. So what are the structures again if I say medial? Again goes back to your motor tract, which is going to be your corticospinal tract. And because it's your midbrain, it has to be your cranial nerve 3. So what is the function of your cranial nerve 3? It is going to help you look towards the upward direction and towards or between the eyebrows, right? Between the eyebrows and up. So if there is a lesion to the cranial nerve 3, what would happen to the eyeball? Will it be able to look up? Will it be able to look to the center of your eyebrows? No, it's going to be down and it's going to be out. It's exactly going to be opposite to what the eyeball is supposed to do. And you know your cranial nerve 3 is also responsible for pupillary constriction. So if the nerve is involved, it is going to lead to dilation of the pupil, right? This is what you learn in pupillary right reflex. So cranial nerve 3 is going to cause an ipsilateral eye down and out along with your dilated pupil. Easy peasy. Now your corticospinal tract, your motor pathway, contralateral hemiplegia. So if you remember this much for your midbrain syndrome, it becomes super easy. So when the question gives you cranial nerve 3 with contralateral hemiplegia, it is going to be a Weber syndrome, right? Now, the last one for today's lecture is going to be on your locked-in syndrome. So locked-in syndrome, you might have heard of patients who are completely like stiff and locked, but only has some, eye motions preserved in them. So let's try to understand what exactly is this locked-in syndrome. So when there is a location or when there's a lesion to the ventral pons, which can also extend sometimes to the midbrain and the medulla, your patients will end up having a locked-in syndrome because now you have your midbrain, medulla, and pons also, which is going to be involved, right? And it's a basilar artery occlusion completely. So what are the structures involved? Remember the presentation for the corticospinal tract is going to be bilateral because you're locked in. Your arms are locked, your legs are locked, you can't really move. So it has to be your bilateral corticospinal tracts, which are going to be involved, leading to quadriplegia. Okay. Now, cranial nerve involvement is definitely going to be there, but remember, your cranial nerve 3 is going to be spared. Okay, so preserved vertical eye movements. Okay, so preserved vertical eye movements, which means how would the patient respond or how did the patient communicate with us? With the vertical eye movements or with the blinking? Remember, your cranial nerve 3 is responsible to keep your eyelids open, right? So that's the reason why you can blink with this presentation, right? So that's how your patients kind of communicate with you. So reticular formation is also spared, and that's the reason why your cautiousness is intact. Your reticular system is responsible for level of cautiousness, right? So if it is spared, obviously there is going to be intact consciousness. So remember, there are only two things: the patient is very well aware of the surroundings, the patient is very cautious, and the patient will have vertical eye movements which are going to be preserved. But can they speak? No. Can they move? No. So the only way they can communicate with us is the vertical eye movements or your blinking, which is going to be seen in this patient with locked-in syndrome. Okay, so this kind of wraps up our topic for today, which is going to be your vertebrobasilar artery syndrome, which starts all the way knowing about the location of the lesion, whether it's midbrain, pons, and medulla. How do you know the location? You have to look at the cranial nerves. If it hints you towards 3 and 4, it's mostly your midbrain. If it's 5, 6, 7, 8, it's your pons. If it's 9, 10, 11, 12, it's going to hint you towards your medulla. And remember, if it's on the medial side, you need to look at those 4 M's. Is the corticospinal tract involved or not, right? So if you go back to the slide, you need to search for, are these present for me to choose the medial side syndrome, right? Or medial involvement of your lesion, right? And if it's the lateral side, look for those S's, right? You need to look for, is spinothalamic tract mentioned? Is sensory nucleus of trigeminal nerve mentioned? Is spinocerebellar tract mentioned? Or spinocerebellar involvement mentioned? So these will hint you towards if it's a medial lesion or if it's a lateral lesion. And the most important syndromes has been covered today, like your medullary syndrome. Remember, your Wallenberg syndrome is important, which is your lateral medullary syndrome. And then your Weber syndrome is super important. In pons, I believe that you have to know medial inferior pontine syndrome and your lateral inferior pontine syndrome. So hopefully this was helpful. And please let me know if there is anything else you would like to, learn, or if there's anything else you would like me to actually like focus more on so that I can help you with any topic which is required to ace your NPTE. Take care. See you again in the next class.